Okay, let's dive right into our roadmap for today. We'll start with the Todani classification breakdown, move into surgical management by type, hit those key clinical pearls, avoid the classic exam traps, and then finish up with a quick recall question.
All right, Part 1, the Todani classification breakdown, mapping the biliary tree.
To really truly memorize this whole system, you've got to treat it like a visual memory journey. When we map out all 5 types, a super logical anatomical flow just instantly reveals itself. We're not just memorizing random Roman numerals here. We are actually moving from extrahepatic disease, meaning, outside the liver, down into the duodenum, and then tracing it all the way back up deep into the intrahepatic ducts inside the liver. So, type 1 is extrahepatic. Type 2 is a diverticulum. Type 3 dips right into the duodenum. Type 4 involves multiple cysts, and type 5 is strictly intrahepatic. Let's break these down one by one.
Let's build that anatomical foundation. Type I is a single, cystic or fusiform dilatation of the extrahepatic bile duct. Simply put, it's just one extrahepatic cyst. Now contrast that with type 2, which is an outpouching, or a diverticulum, arising directly from the duct itself. You really want to visually anchor these first 2 distinct extrahepatic presentations in your mind. Type I essentially widens the entire duct, right? Whereas type 2 is just a little pocket sort of hanging off the side of it.
Moving further down the tract, we hit type 3, also known as a Choledochal. This is a dilatation of the intraduodenal distal common bile duct. I really want to emphasize that unique distal location right at the duodenal wall. Think of it essentially as a cyst bulging right into the duodenum. Remembering that specific intraduodenal keyword is absolutely crucial. It's going to completely prevent you from confusing it with the other types when you're staring down a super tricky multiple-choice question.
Now, type 4 is all about multiple cysts, but you absolutely must know the subvariants. Type 4A features dilation of both the intrahepatic and extrahepatic bile ducts. It literally crosses the boundary. Type 4B, on the other hand, is strictly multiple extrahepatic bile duct cysts only. The liver itself is totally spared. Examiners love, and I mean love, to test this exact distinction. So lock in this visual right now. IVA is everywhere, IVB stays strictly outside the liver.
And finally, we reach the end of our visual memory journey with type V. This one is entirely inside the liver. Type V is defined as multiple intrahepatic cysts only, no extrahepatic involvement whatsoever. And you must inextricably link type V in your mind with its eponymous name, Caroli disease. Literally, if you see Caroli disease on a test, you are looking at a Todani type V. No questions asked.
Okay, Part 2, surgical management by type. From diagnosis to the OR.
So now that we can identify these cysts, the urgent question becomes, how do we surgically manage them? We need to prevent complications like cholangiocarcinoma. And, just as importantly, we want to score maximum exam points. For type 1, which by the way is by far the most common type of choledochal cyst you're ever going to encounter, the standard surgical treatment requires 3 mandatory steps. First, complete excision of the cyst. You have got to get it all out because of that high malignancy risk. Second, a cholecystectomy. Yup, the gallbladder comes out too. And third, to restore biliary flow, you perform a Roux-en-Y hepatojejunostomy. Whatever you do, do not forget any of those 3 steps. For the remaining types, I want you to notice how the aggressiveness of the treatment scales directly with the anatomical extent of the disease that we just mapped out. Type 2 is a simple diverticulum, right? So you just do a complete excision of that diverticulum and reconstruct if needed. Type 3, being right down at the duodenum, can often be managed with endoscopic sphincterotomy or a transduodenal surgical excision. Now for types 4A and 4B, you've got to excise the extrahepatic disease, but 4A might also require a hepatic resection if the intrahepatic disease happens to be localized. And finally, type 5, Caroli disease. If it's localized, you can resect that specific part of the liver. But if it's diffuse, spread all throughout the liver, then you're looking at medical management of complications or ultimately a full liver transplant.
Moving on to Part 3, key clinical pearls, the most tested facts.
All right, we're shifting gears into ultra-high yield mode here, speaking directly to those test-taking anxieties. This right here is arguably the single most tested distinction in the entire classification system. You need to burn this into your visual memory. IVA is intrahepatic plus extrahepatic. IVB is multiple extrahepatic only.
So when you're reading a clinical vignette, the absolute second they mention cysts both inside and outside the liver, your brain should immediately snap to IVA.
And here's your next massive clinical pearl. Type V equals Caroli disease. Caroli disease equals type V. They are completely synonymous in the context of this classification. When you see a question describing a patient with exclusively intrahepatic biliary cysts, you don't even need to think twice about it. Boom, it's type V.
Part 4. Classic exam traps. Avoid lost points.
Look, knowing the right answer is really only half the battle, isn't it? The other half is navigating the tricky distractor answers that question writers designed specifically to steal your points. Here's a super classic anatomical mix-up trap, confusing the locations of type 3 and type 5. Type 3, the Choledochal seal, is all the way down at the intraduodenal distal common bile duct. Type 5, Caroli disease, is all the way up top in the deep intrahepatic ducts. One is quite literally as far down the biliary tree as you can go, while the other is completely inside the liver. Keep those geographical extremes totally separated in your mind.
Now here is a massive trap. Please listen to this. For a type I choledochal cyst, you will almost always see an answer choice offering simple cyst drainage or internal drainage. Do not pick it. Simple drainage leaves the cyst wall behind, and because that specific tissue has a highly elevated risk of turning into cholangiocarcinoma, just leaving it there is completely inadequate. The standard, totally correct operation is complete cyst excision with a Roux-en-Y hepatocogyginostomy. Never ever settle for just drainage.
And finally, Part 5. Quick recall question. Let's test your knowledge.
It's time to actively apply exactly what we've been talking about to simulate exam day. Here is your prompt. A patient has multiple cystic dilatations involving both the intrahepatic and extrahepatic biliary tree. Lock in your answer right now. What Todani type is this? Think about the map we just built. Multiple cysts. Crossing the liver boundary, what is it?
Boom! The answer is type 4A. If you got that right, huge congrats, because you have successfully mastered the most highly tested distinction in the entire Todani system. You successfully identified that because it involved both intra- and extrahepatic ducts, it couldn't be IVB since that's extrahepatic only, and it definitely couldn't be type 5, which is intrahepatic only. Fantastic work validating your revision effort today.
So, as we wrap things up today, I want you to ask yourself, how will you use this visual memory framework to completely dominate your next surgical rotation or board exam? Because honestly, that's the real power of learning this way. You aren't just, memorizing bullet points by rote. You've actually built a spatial map in your mind that you can casually walk through under pressure. Take this confidence straight into the clinic, trust those structured visuals we covered, and I will see you in the next explainer.